Chinoy from the University of Manchester. Hector Chinoy is a very known expert on myositis, and he has done a great of both clinical and research work. And he is the professor of rheumatology and musculoskeletal diseases at Manchester. And he is also the chair of MyoNet Consortium and Registry. Please welcome Dr. Chinoy.
So thank you very much for the kind introduction, Helen, and welcome to the UK and London. I hope you're enjoying our beautiful weather here, which we've specially put on for you. Okay, these are my disclosures, and these are the objectives which you'll see in the program already. So the plan for the talk today is we're going to do a bit of background, try and answer the question why, some diagnostic tools, antibodies, treatments and clinical trials, and the MDT approach. So let's start off with diagnostic tools. I draw your attention to this BMJ best practice online. This is something that we have to update every couple of years. It's free to access, so I'd encourage you to have a look at this. And thank you for Thomas Koo for producing this, and I tend to start off my talk with this to give you an idea of where we've gone in the last 25, 30 years, moving away from the archaic terms of PM and dermatomyositis from Bone and Peter. And then there's gradual chunks that have been taken out of the term that the artist previously known as polymyositis. So we've got inclusion body myositis, which needs to be taken into account, immune-mediated necrotizing myopathy. Then we've got overlap myositis, which transcends both PM and DM, and also anti-synthetase syndrome. And once you've taken these conditions away, you're not left with very much that you would define as PM. So one thing to just take away from today's talk is try not to refer to your patients as having polymyositis, but think about specifically which clinical subtype they've got, and also which antibody is associated with these particular conditions. And we're lucky enough that we can now test for most of these antibodies with commercial immunoassays, which then help to define the clinical phenotype, be it lung disease, skin disease, or malignancy. There's a beautiful review recently published in the New England Journal from Eve Allenbach and Olivia Benveniste. And one of the slightly sad things I like to do is guess the antibody. So when you're seeing a patient for the first time, you're thinking, oh yeah, this is a, Bond or NXP2. And then you wait for the antibody and see if you're right or not. So here on the left, what this is trying to illustrate is the importance of triangulating the diagnosis with all of the information that you have to. So at the top, we've got the clinical pattern of weakness, inclusion body, the forearm wasting, the asymmetric quadriceps wasting, and then the MR can give some valuable clues. If you see T1 weighted fatty involvement at presentation, just think about IBM or even a genetic myopathy. And then the fasciitis findings you may see in dermatomyositis or even anti-synthetase. What is the CK at baseline? A lower CK less than 1,000 would be in keeping with IBM. A really high CK in the thousands, have a think about IMNM. Have you checked the HMGCR antibody? And the CK may often has not been normal in dermatomyositis, so please bear that in mind. And then there's the more characteristic histological findings as well. So then we get on to the extramuscular manifestations. And remember, we should be referring to this condition as myositis spectrum disease, not myositis, because not all patients present with muscle involvement. There may be dermatological involvement. And we can see here on the graphs that Eve and Olivia have shown the proportion of patients who present with these. So about 30–40% of anti-synthetase patients can have dermatomyositis manifestations, for example. Swallowing issues, dysphagia can be seen across the board. Respiratory tends to be more common in anti-synthetase patients, but also remember about MDA5, PMSCL, and COO. Cardiac is generally uncommon but under-recognized in IIM. And then always think of the cancer association, especially in dermatomyositis and TIF1 gamma. And then joint involvement tends to be more common in antisynthetase syndrome. So why does inflammatory myopathy develop? And this is beautiful seminal work that's been done by Iago Pinal-Fernandez and Andy Mammon, and looking at RNA expression work. And we all know that autoimmune diseases arises from people who are genetically susceptible and they've had environmental exposures throughout their life course, which then will eventually predispose and there'll be a trigger that commences the autoimmune process. The production of myositis-specific antibodies, which are being increasingly accepted as being pathogenic and having a role in the overall disease process. Iago eloquently presented this morning, and I urge you to dig out his abstract about the identification and mechanism of the actual internalization of the antibodies into the muscle cell, where they cause damage depending on what their identity is. So, for example, Me2 is a histone deacetylase complex, and an antibody working against this, it disrupts the RNA machinery, which leads to transcriptional derepression and muscle involvement. PMSCL is part of the exosome complex, which then will lead to defective RNA degradation. So let's turn our gaze towards muscle enzymes now. I will draw your attention to the EAN 2024 guidelines. I know this WIN talk is supposed to be updated the last 12 months, and these EAN 24 guidelines were published in February 2026. So, but it's a really useful flow chart you'll see on the left-hand side, which may give you some guidance about how to approach a patient with a raised CK. So, for example, hyper-CKemia greater than 1.5 times upper limit of normal, yes. First thing, repeat it after a month. Still raised, then start probing about family history. Is there a history of malignant hyperthermia? Consanguinity, asking that in the most tactful way you can. And two of the tests that we commonly do in our clinic in Salford is we'll send off a dried blood spot test for Pompe disease, looking for acid glucosidases, because Pompe is a treatable glycogen storage disease. And we'll also send acyl carnitine levels if we're looking for things like CPT2 or maybe a functional MAD with a drug like sertraline. So we did a QI project looking at our own data, and we found what we wanted to know was, when do we get excited? At what level of CK do we get excited? And is it likely to be a thing if the CK is only 400 or 500? We divided our patients according to whether they actually had IIM or whether they had a defined non-inflammatory myopathy or an alternative / reassuring etiology, which was not muscle in origin. And the conclusion we came to was it was difficult to differentiate between IIM and non-IIM myopathy based on the CK alone. But the majority of patients who had a CK less than 1,000 were compartmentalized into this alternative reassuring. So it could be you still got a CK less than 1,000, you've got IIM, but if you've got a CK greater than 1,000, it's likely to be pathological in some description. Okay, let's move on to antibodies now. And this is a lovely chart from Sarah Tansley's review published last year. And Bath have been seminal in antibody discovery over the years, and I was lucky enough to be part of this in the early 2000s, where you can see this plethora of antibody discovery. I was also privileged to work with Robert Bernstein, who first described Jo1 in 1980. And then if you kind of look further back here, and then if you start to realize that before 1984, that Rho wasn't actually readily detectable on assays. It wasn't actually discovered before 1984. And you think, well, what antibodies could one actually test for in the early 1980s? How do you manage? It's a bit like the millennials and Generation X say, how did you manage without a mobile phone? It's, how did you manage without autoantibody testing? And then if you look further forwards, there's all these other antibodies which are not commercially available yet. I think probably the latest, which is now commercially available, which is really useful, is HMGCR, which really has transformed our understanding of IMM, thanks to Lisa Christopher Stein and Andy Mammon. On the top right, you'll see CCAR1 and SP4, and these are antibodies that coexist with TIF1 gamma and appear to confer a protective element for malignancy in the setting of TIF1 gamma. What happens if you get your local lab to test a sample that you know to be a true positive? So it's almost that you're, you're infiltrating the ranks and you send them a sample. It's like, I know what this is, and let's see what they're going to show. So this was a study that was published just last month, where 25 samples were shared with participating laboratories and reported findings in reference to the baseline MSA-MAA result. So the y-axis is the number of laboratories who received and interpreted the sample, and if we look at the left-hand side, we can see anti-Me2. The blue bar is when the lab reported the result correctly for the baseline sample. The green is when the lab reported as negative for that particular sample. So for anti-Me2, they did pretty well. In 11 out of 12 laboratories, they correctly reported the Me2 result. Similarly, PL7, NXP2 did well. But look at TIF1 gamma, that of the 15 laboratories who reported the result, 6 of them actually reported the result as negative. So I think the message here is we not only come across false positives, but we can also come across false negative results. So just because you're getting a negative result from your laboratory, it's not necessarily dismissing the phenotype. I know I do talk about how I don't believe in seronegative polymyositis, etc., but it's how you get the results from your lab as well. And remember that at about 20% of dermatomyositis is actually seronegative, or at least we can't detect the antibodies as yet. Okay, so then what happens if you compare the performance of hospital immunology labs against immunoprecipitation assays as a reference standard? And this is a meta-analysis that was published last December. And this was a huge project that was undertaken and coordinated by Takehisa Gono. And we started off with about 3,000 studies and then whittled them down into 23, and a meta-analysis was performed for antibodies which were available. And you can see the horizontal box plots on the left-hand side, the pooled sensitivity for a particular antibody, and then the pooled specificity on the right-hand side. The first thing that strikes you is the specificity is very high, and it's because a lot of these antibodies are just testing negative, so naturally the specificity is then going to be high. But if you look at the sensitivity, it does broadly go align with the previous slide I showed you. So the sensitivities are rather low for NXP2, for EJ, and then the better ones that are performing are SAE, MDA5, PL7, and JO1. So false positive and negatives remain a significant challenge for commercial assays. But hey, at least we've got access to something which we just simply didn't have 10 years ago. Inaccurate results can influence key medical decisions, so you have to be confident in your clinical diagnosis. Don't always trust what the lab tells you, and consider these potential technical issues. So for example, increasing the temperature of your laboratory could affect your the results on a day-to-day basis. So what about the Euroimmune blot? And this is something that's commonly used, certainly within Europe and now in other countries as well. There is an issue with false positives. We talked about this already. So for example, if you have a low pretest probability that your patient's actually going to have IIM in the first place, I think it's worth just considering whether you actually do the antibody test in the first place. If you don't think your patient's got myositis, it's not necessarily a good test to do. So a few examples here. If you have a single Me2 alpha or beta, or a single PMSCL 75 or 100 without an ANA nucleolar to confirm it, a weak positive result, a weak positive JO1 or SRP, OJ performs notoriously badly on the blot. So if you ever get a positive OJ, really look at that with suspicion. And then combination weak specificities is something to be looked at with suspicion as well. A lot of these antibodies are mutually exclusive and shouldn't occur in combination with each other. Okay, so now we're going to move on to current treatment, because that's where it's all at with myositis. And in order to do that, we have to go back to the future first. And so this is a review from Chet Otis and Rohit Agarwal from 2018. And this really is the paradigm, really, of what we're doing at the moment. And patients are dependent on glucocorticoids with associated long-term side effects, refractory disease activity, and a lack of licensed treatment all round. And what Chet and Rohit quite correctly state is we're reasonably starting off with steroids, and then this can vary depending on practices globally, but typically one may be using anything from methotrexate, azathioprine, mycophenolate, tacrolimus. And then if you failed on 2 or more of these drugs, then we're moving on to other things such as rituximab, other B-cell therapies, abatacept. And then IVIG is always the option if you need a rescue, if the patient's got dysphagia or severe recalcitrant skin disease. Just to quickly tell you about TIS and the myositis core set measures, it's worth measuring disease activity not just with a CK, but a combination of things. And these are easy to do in clinical practice. You don't have to calculate a total improvement score, but I would implore you to at least quantify the muscle strength with the manual muscle testing score. The maximum you can get is 150 bilaterally. Then there's 3 visual analog scales. There's an extramuscular score, physician MD global, and a patient global. Then there's a HAC and a CK level or other muscle enzymes. There's also the CDASI, which is a great tool to measure and quantify skin disease. And you can measure disease activity with the CDASI, which does this survey according to anatomical location, and then rates by erythema scale in the presence or absence of erosions and ulcerations. Okay, so now let's move on to current clinical trials. And what's really amazing is there's just this goldmine of current clinical trials in myositis. We're almost at where rheumatoid was about 20 years ago. And you don't need to look at the detail here, but this is just a snapshot of what's happening on clinicaltrials.gov at the moment. And you'll see at the top, there's CAR therapy and the number of active trials. There's 49 CAR trials registered on clinicaltrials.gov in myositis alone at the moment, which is just remarkable. So this is a review from December from Laura Gallet and Rohit Agarwal and team, and a really nice just summary picture. So starting on the left, what agents have we got at our disposal? There's IVIG, the idea of complement inhibition. Then we've got FcRn blockade. I just presented a poster on efgartigimod, which you can refer to. Daratumumab, if you can access it, an anti-CD38. And the CD20s, our friend rituximab. And then at the bottom, there's other B-cell inhibitors, other approaches, including CAR-T and bispecifics. And then on the right, the co-stimulatory blocking of CTLA-4 Ig, abatacept, and then interferon-based drugs. So let's quickly just go through these. So we've got FcRn. I'll just walk you through efgartigimod, which is a human IgG1 antibody Fc fragment engineered for increased affinity to FcRn. So if you look at the cartoon on the right-hand side, the yellow guy is efgartigimod, and the green receptor is FcRn within your cell. And what efgartigimod does is it outcompetes endogenous IgG and pathogenic antibodies for binding to FcRn. It's in the molecule's interest to bind to FcRn because then the molecules stay intact and then escape cellular degradation and then get recycled back into the circulation. If you're not able to bind to FcRn, then what happens is the IgG and pathogenic antibodies are degraded within the lysosome. So efgartigimod basically stops the IgG from binding to FcRn and stops it from getting recycled. But it seems to do this without impacting antibody production or other parts of the immune system or degrading albumin or increasing LDL. So this takes us on to Alkivia. This study was presented last year at EULAR, and the objective was to assess the efficacy of efgartigimod compared to placebo, and the primary endpoint was the total improvement score at week 24. And there was an extension of the study, which we presented just earlier on today, and there's an ongoing phase 3 where there's been a database lock and we wait for the results of the phase 3. But the phase 2 was a positive trial, which is so heartening to see in myositis. And we can see at week 24, there was a significant clinical improvement as measured by the total improvement score with this divergence of the active drug versus placebo. And we have to bear in mind, you may be thinking there was a high placebo response, but the patients, they were allowed up to 20 mg of prednisolone, and they were on background immunosuppressants as well. And then if we break it down into the more categorical TIS 20, 40, 60, if you just think about the equivalent of ACR 20, 40, it's kind of along those lines. You can see a really good TIS 20, but a very, very good placebo response as well. So it's telling us TIS 20 is not really a reliable outcome measure. We can see the divergence with the delta with the TIS 40, comparing the two, and then we can really start to see when we're looking at major improvement. So a very promising therapy, and we await the phase 3. And efgar is a licensed drug for myasthenia and CIDP as well. So let's turn our gaze towards interferon-targeted therapies. Historically, there's been this drug called cifalimumab, which was a MedImmune drug targeting interferon alpha. There's also dazukibart targeting interferon beta, and anifrolumab, which many of you will be familiar with in lupus, the IFNAR1 receptor blocker, and then JAK inhibitors. So initially, let's quickly touch on JAK inhibitors, and there's one trial I just want to tell you about, which was the VALOR phase 3 study, and this was a 52-week double-blind placebo-controlled study of dermatomyositis, the largest trial to date in dermato, 241 patients with 2 doses compared to placebo. And the primary endpoint was the 30 mg versus placebo mean total improvement score at week 52. So this is the TIS over the mean TIS plotted over time up to week 52. The top 2 lines are Brepo 30, Brepo 15 compared to placebo. And you can see a significant divergence of the drug at week 52. And even at an early stage, by about week 12, you're seeing a divergence compared to placebo. On the right-hand side, you'll also see a secondary endpoint where there's the effect of steroid reduction. So 42% of the Brepo patients managed to get off steroids at month 12 as well. So again, amazing to get a positive study, and this time this is a phase 3, so the company are now awaiting approval, hopefully for the drug. And these are the TIS40 and TIS60 results. And on the right-hand side, you'll now see a combined outcome of moderate TIS with a reduction of steroids. And on the right-hand side, you can start to see a real divergence of the drug versus placebo once you bring the steroids below 2.5 milligrams. Okay, so now anifrolumab. So this is an IFN-AR1 inhibitor. This is under trial at the moment. So the Jasmine study is a multi-center global study. There's over 100 sites currently recruiting to this phase 3 study in polymyositis and dermatomyositis. So we eagerly wait the results of this. What I can show you is a really neat Spanish study of 30 patients with refractory DM. And thank you to Shri Karet and Rohit for these slides. So these patients failed an average of 5 prior therapies, including 70% failed IVIG, half of them failed a JAK, 27% failed rituximab. The mean disease duration, 4 years. So, and 60% were on PRED at a mean dose of 10 milligrams daily. So if you look at the mean MMT8 over time, you can see an improvement up to month 12 once they started anifrolumab. And then on the right-hand side, we've plotted out CK and ferritin over time. And you can see this normalization from a median of 332 to 146. So it's what you have to bear in mind is with these patients, there's a profound improvement in what looks like a highly refractory group of patients. I told you about the CDASI earlier on, and we can see, so a higher CDASI indicates higher disease activity, and you can see this marked drop over time of the CDASI with a median of going from 23 down to 2.5 at month 12. So at least in a case series, this drug is showing some promise, even in patients who have failed JAK inhibition. And then the next drug to look at for the interferon-targeted therapies is dezucabart. This is a Pfizer drug, and it, again, is currently under phase 3. So we await the results here, but there has been a published phase 2 trial, which was published in the Lancet last year. And I'm just showing 2 snippets from here. And on the left-hand side, we can see the change in CDASI over time in the dezucabart 600 mg dose compared to placebo. And then on the right-hand side, the change in 13 gene signature interferon score, which doesn't change in placebo, but profoundly goes down in both dezucabart doses. Okay, so now I'm sure you're sick to death about hearing about CAR-T, but you're going to hear a few more slides now regarding CAR-T and this idea of a deeper B-cell level depletion than what we're currently undertaking in CTDs. And a lot of the CAR-T you will have heard about is targeting CD19, which has a wider spectrum of B-cell targeting than CD20 does, which rituximab is. And then you'll also have heard of BCMA, which is targeting the more mature B cells, the plasmablasts and the plasma cells. So I mentioned before about the N equals 49, and this just gives you an idea of the mechanisms that are being looked at currently. And you can look up this information yourself on clinicaltrials.gov. I'll give you a few slides from some available data as part of a study, and this is the Cabaletta Reset Myositis study, which was a phase 1/2 study, recruiting patients with IIM, with dermatomyositis, antisynthetase and IMNM, and also juvenile myositis as well. This is autologous CAR-T, so the patients receive leukapheresis, then preconditioning with fludarabine and cyclophosphamide, and then a single infusion of their cells. And the primary endpoint was day 29, incidence and severity of adverse events. And the patients basically had to come off treatment once they received their product. So this is some of the data for dermatomyositis. And in fact, there's more updated data that has been presented at this conference. On the left-hand side, you'll see a summary of the 4 patients. And on the right-hand side is the TIS score. And we see a rapid improvement into the major category for dermatomyositis. And this is with discontinuation of their immunosuppressant treatment as well. So for DM, that we're meeting this pivotal study primary endpoint as well, which is achievement of a moderate TIS and off all IIM therapy, or no steroids or low dose. And what we also saw was a very, very low incidence, if any, of any AEs in these patients as well. So then this is follow-up data in DM and JDM. And this was only released in the public domain yesterday. So we can see there's more patients now that have been dosed, including a JDM patient, where we can see ongoing efficacy in the patients who have been followed up to the and beyond the week 52 mark. And 86% of these patients would meet moderate or major TIS off IIM therapy on low dose or no glucocorticoids. So then if we look at IMNM patients, the story is slightly different, and there's a general improvement in these patients, but not all of them are meeting an endpoint of moderate improvement. So we have to bear in mind that where these patients are starting at and the sort of patients that will be recruited into a study like this, where they've had multiple previous treatments. So there is an improvement, but perhaps we're not seeing the immune reset in these patients. This is an interesting study to point you towards, and this was published last year from the German team from Erlangen, and this was an N=1, but I just think it's really interesting of a patient with anti-synthetase syndrome with JO1 who received a CD19 CAR T. And there was an initial very good improvement, but then the patient relapsed. They received a second lot of CD19 CAR T. Then they relapsed, they received daratumumab. And then they decided to go further down the B-cell lineage, and then the patient received BCMA CAR T. And the patient did respond and go into remission. What is interesting to observe, though, is that the JO1 titer did remain high. And honestly, we just don't really understand what this means. And it's perhaps, if a patient remains in remission, but then the titer still remains raised, this is out of keeping in what we may see in GPA or in lupus. So maybe it's not as important for us to track the titers in anti-synthetase in myositis. I think there's just a lot we don't understand, but at the same time, a lot we learn from every single patient who receives these novel treatments. And what is actually going on in terms of so-called resistance to CAR T? Is it that the pathogenic B cells are predominantly plasma cells rather than CD19 expressing? Is it that there's a protected niche that shields these patients from the therapy? So this is a lovely review that was published again by Rohit last month. And then the other philosophical question is what do you actually do with these patients afterwards if they're failing these experimental therapies? And I think there's going to be a talk about that tomorrow. So I just want to finish off, if that's all right, Helen and Kazi, about T-cell targeted therapies. And I think for general rheumatology and for myself, we're playing a rapid catch-up with the science, and we're being forced to catch up with what is already known about these technologies, what's being used in oncology, and what we're maybe using in the next 5 years. And how do we convey this science to the patients? So there are these T-cell engagers. The ones that are being used in oncology include teclistamab and blinatumomab. And there's agents in trial at the moment as well. So there's 2 interesting case series of T-cell engagers in IIM, one of which used teclistamab, and then the other one which has just been published in Nature Medicine in April. It was a study of teclistamab in systemic sclerosis and 5 patients with JO1 who received low-dose blinatumomab. So these, on the top, this is the patient 1 who received blinatumomab, and you can see the plotting of the CK. So initially when they received blinatumomab, there was a profound improvement of the CK, but then they flared, they had to have more blinatumomab, and then the purple is the 6-minute walk distance, which is gradually improving over time. On the right-hand side, you can see the FVC, which there's a maintenance, and the DLCO is pretty much remaining the same. And then the patients receiving rituximab over time as well. On the bottom, you can see the 5 patients and what happened to their CD19 levels. And in 3 of them, actually the CD19 levels went back up. The blue line, this particular patient did have a relapse, and then one of these other patients, they went into complete remission despite an increase in the levels as well. So again, a lot we just don't understand about what's going on. But having talked to the authors about this, it's maybe we should be realigning ourselves here, that perhaps in some of these immune-mediated diseases, perhaps an immune reset it's asking the earth, and perhaps that's not going to be realistic for all of our patients. But if we're at least looking for a new baseline for these patients, or a so-called immune dimming. So how will this translate into future IIM treatment strategies? So what we've seen so far with cell therapies, at least the case reports, is that they've been targeting prevalent multi-drug resistant patients. And in the future, this may not be the same demographic of what we're treating. So I've just put an EG here of a patient of mine who's recently received a cell-based therapy who had failed on all of those drugs. And it's difficult to know where you go next with these patients. Interferon inhibition, I think it's going to be dermatomyositis and antisynthetase syndrome where we're going to be using these therapeutic targets. FcRn is really interesting, and it could be a viable alternative to IVIG. It's certainly a lot more convenient than having to get patients in for days at a time for monthly infusions. What about CAR-T? Will we be using these in our rituximab failures, presumably in antibody-positive patients? And will it become practically easier to administer this type of treatment in the future? And T-cell engagers may prove to be a more practical, cost-effective route where CAR-T is not appropriate. So there are unmet needs, and it's important we do an MDT approach. This is a lovely paper from Julie Paik, and there is a need for consensus-driven standardized guidelines, but also standardized guidelines as to what we do with these very multi-drug resistant patients in the future. And the goals at the end of the day for the patient is what they want is they want an improvement of their quality of life, and they want to become functional again. So use your clinical skills and diagnostic tools to accurately diagnose the disease. Learn how to correctly interpret your laboratory's antibody results. There's up-and-coming new therapies to choose from. Neurotherapies are teaching us more about the pathotypes. And what is your patient objective? Do they really want an immune reset or just to be in a better place? So thank you for your time, and I welcome questions.
Thank you, Hector. Excellent talk. Do we have questions for Professor Chinoy? I can see some. Yeah, there is one. Yeah.
Thank you, Murat from Istanbul. Thank you, Hector. Very nice review and new studies. Two questions. One is practical. After all these new treatments, is your using of glucocorticoids changed? I mean, like lupus studies, lower dosages, starting dosages, more pulses. This is the first one. The second one is, all these environment, what is the place of histology now? We all skip muscle histology, or it's going to have some help in our future studies?
Even using rituximab allows a realistic reduction in steroids. And if you formally measure this in your patients, you will find that it can provide a meaningful reduction in steroids. So the short answer to the first question is yes, that this is what we hope. And we hope to move away from using steroids in the future. Secondly, histology remains really important. And I've actually started to do more histology than I was doing 10 years ago, because it teaches us a lot about what's going on in the patient. It helps to exclude non-inflammatory myopathy as well.
Thank you.
Professor, what is your approach in patients with dermatomyositis with MDA5 with lung involvement in terms of start treatment, triple therapy, step up? What do you think?
So the question is about MDA5 and rapidly progressive interstitial lung disease. And these are patients where we need to be on high alert. We need to be aware of the rapid requirement for step up in treatment. And what you use will depend on really which country you're in and your accessibility to the drugs. But the traditional approach of triple therapy still remains valid. So high-dose steroids, cyclophosphamide, and then tacro or a JAK inhibitor is probably the basic requirement of where to go.
There are also lots of questions in the chat, but I fear we can't go through all of them because of time issues. Just one, Hector, what do you think about nutrition advice in refractory myositis patients as a non-pharmacologic nutrition? Yeah.
Oh, well, I mean, nutrition itself is really important, and I think we always encourage our patients to increase their protein intake, and maybe moving from a 1.2 or 1.5 grams per kilo per day protein, maybe even up to a 2, just so that they get a maintenance of their muscle mass, but ideally in conjunction with some gentle exercise. The evidence for creatine supplementation is limited. There has been one study in myositis which showed that it didn't do any harm, but that's about where we're at with nutrition. I think there's a lot of work to be done, but fiendishly difficult to do nutrition studies in these conditions.
Okay, so thank you very much, Hector. Excellent talk, and also for you for participating. Thanks very much.